Hey, David, is that Amazon drone delivering your book?
Hey, John, actually, I ordered a new kidney for my brother. Welcome to CareTalk, your monthly home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix.
John, I saw a wild article the other day, and it was about a drone.
How wild was it?
It was this wild, John. It was a drone delivering a kidney for transplant in a patient in Maryland.
David.
Pretty crazy.
David.
Is it like a publicity stunt or the real thing?
Drones are the future, dude. I mean, you are missing a lot. There's a tremendous movement to use drones as delivery for critical medicines around the world. I don't know whether you've seen this company Zipline, but in Rwanda, they can guarantee delivery within 30 minutes of bloods and drugs that are absolutely critical to life-saving when the trip used to take 3 to 5 hours if it happened at all. There's 3 billion people around the world who don't have access to critical medicine or blood on a real-time basis. And if you're a mom bleeding out postpartum and you need blood, this kind of service is critical. And it's already established and it already works. I think you're going to see the adoption of drone technology, which is rapidly getting cheaper and more effective to deliver critical medicines, even in difficult parts of the U.S., and it's going to be a game changer for access to critical medicines, I think, around the world. That kidney example is not unique, and I think that drones would make a lot of sense. What's wrong with drones?
I didn't say anything's wrong with it, but I think you're pointing out that it's got to have like an edge case, a very elite thing. You're not going to deliver that many kidneys, but there's always the need for blood in remote areas. In China, they've got a company called Ehang, as long as we're moving around the world, and this company can actually carry a drone that can actually carry a person. And they're talking about using it for lung transplants. I'm a little worried, John. It may come out, grab you, and harvest you.
I don't want to talk
enough about that.
I don't want to talk about China, but
Fine.
Drones are the future of transport.
Fine.
Think of it as a future transportation vehicle.
I'll think about it that way, John. But let's talk about disparities, since you're sort of bringing it up with my Maryland example, your Rwanda example.
The disparities don't just happen in terms of access to care in Africa. There's these huge disparities. There's more and more statistical evidence that the disparities in the U.S. are getting worse, not better, and are not being addressed. If you just look at the wealth disparity, one statistic, the Brookings a few years figured out or tested, what's the difference between the lifespan of a wealthy person and a poor person? One cohort born in 1920, the other in 1940. If you were born in 1920 and you were wealthy versus poor, you lived 5 years longer. If you were born in 1940, again, with more access to more modern technology, the actual disparity between wealth and poor lifespans was up to 12 years. What you're seeing is disparities are growing as opposed to declining in the modern world. And that's crazy. And you see it across race, gender, as well as poverty. And if we're going to fix the U.S. healthcare system, we need to invest more resources, not just studying it, but addressing these issues.
Well, John, I think you pointed out with the drones how that can actually reduce disparities with your example of Rwanda. And I think technology has the possibility to reduce disparities, but also to increase them. And I wouldn't be surprised if
How do you get there?
I'll tell you why. I wouldn't be surprised to see if your 5 years to 12 years actually goes to 20 years or 50 years in the future, because as people can actually invest in being able to get artificial organs, there's going to be kind of cyborgs. I know you don't like the term. And people, there's really going to be the part of me. What's really going to happen is there's going to be a huge disparity between people that can afford to replace their own organs and those that can't. But John, I know you don't like that idea, but what's happening right now is, if you think about how do you measure disparities, one way that I read that was very disturbing was in looking at outcomes of people with diabetes. And an African American is up to 10 times as likely as a white person to lose their leg to amputation from diabetes. And that is a very sad state of affairs, John.
Well, you're way too afraid of technology, and I think actually technology can also help us leverage more of the increasingly shrinking physician and clinical workforce that we need to augment. So augmented healthcare is going to be your friend, David. And if we were ever able to actually successfully manage the pricing of drugs and hard technology, you shouldn't be afraid of a cheaper heart that works well, that would be accessible.
I'll take one of those 1.5 or 2 valve hearts, John. I don't need all the valves.
But I think that the challenge on race is actually even deeper. If you actually statistically look and you normalize for access to care and income, what you find is for African American men, you still have worse disparities, which is worse outcomes, even across wealth and access to care, which is just crazy. We have to invest in it. But technology is your pal.
But John, you can look
fight
up
it.
if you look up disparities. If you look up David Williams, you'll find it. David Williams, believe it or not, there's more than one who's actually at the Harvard School of Public Health. And he's written a lot about implicit biases that are there. Even when you have a well-defined protocol, somebody from a disadvantaged group like African American are going to be less likely to have that protocol
But why
applied.
wouldn't technology help there? Because
It might.
technology is race blind. And we need to be more blind to race,
All right.
gender, and income.
We'll move on, but I think some of the artificial intelligence databases have been shown that they can actually reinforce the bias.
They do.
So let's talk about some more technology, since you want to talk about that. And you say, I'm afraid of it. I'm not afraid, John. I'm not afraid of technology. But one of the things that's happening is you've got insurance companies like Humana that are experimenting with companies like Doctors on Demand and Teladoc to offer a virtual first approach. So instead of seeing an actual doctor, you're going to see, I guess, your phone. Is that the idea?
Well, don't be afraid. Again, fear not your phone.
Okay, I'll just be dismissive of it.
I think
Where'd my phone go anyway?
We need to leverage all the tools we have to get people access to care, when it's convenient, and access to resources. I think it's been shown over time that if we can get people access to convenient care and cheaper, which all of this telemedicine provides, you actually have better use and more thoughtful use. You avoid the unnecessary script, the unnecessary test, and you're meeting people where they are. I don't know whether it's going to be virtual first or virtual but I think virtual visits are being embraced. You're seeing it not just with startups, but you're seeing people. My 85-year-old mother is very comfortable with technology as long as it gets her the access to the information she needs. It's not going to replace docs. We actually need more heart-centered, humane care, but it gives us an ability to augment and grow access to care when people need it. A lot of what goes wrong in healthcare happens on nights and weekends. I know at CareCentrix, we focus a lot on being accessible to our patients in need 7/24, 365, because that's the only way you can truly get people, you solve for some of those access to care things that happen just based on the work week.
That's fine, John. I think the tech works. It's okay. But would be concerned about getting virtual care when I actually need real care.
Don't be a fraidy cat.
All right.
What do you think about this CBO report about Medicare for All? It's getting a lot of attention. What say you?
So, John, everybody's been talking about how expensive Medicare for All will be, and I'm sure it will be expensive. So they asked the CBO to issue a report, as they often do. They didn't come up with any numbers, even though on things like
Isn't it the Congressional Budget Office?
Yeah. So like they should talk about, it should be more quantitative, but you look through the report, there's not much in there. I think it's because it's hard to define what Medicare for All actually is.
That makes a lot of sense.
And certainly it's going to be expensive, but they point out some interesting things, which is that not everybody has, even if they have employer-based health insurance, it's not as though they keep it for that long. And so you're comparing like Medicare for All versus talking about being scared with, okay, something boo, someone's going to take away my health insurance. Well, people get their health insurance taken away all the time by their employer.
I don't think that's fair. I think that they clearly dodged the bullet. But this year, Medicare for All is really a shroud around the fact that we're losing access to care. Care is still expensive. Drugs are still expensive. And people are angry about it. I think it's a cluster term that's pulling together all of the things that people don't like about healthcare, and they want the public's demanding some sort of action. When you take Medicare for All and you poll for it, it's like 80% approval. When you point out the fact that 140 people are going to lose their private health care, which actually covers more, provides dental and a whole series of other things, you get about 60, 40, 70, 30 against. But we need to pay attention to the fact that we are having issues with access to care. I think that we've talked about this, that there's a solution would be more managed Medicare or Medicaid-like products for people who can't afford it. That's probably where we land. And I think CBO dodged the bullet on pricing it because, to your point, they don't know what it is.
It's a simple slogan and probably shouldn't make policy completely on that. I think one thing to point out is that in the insurance system that we have now, the insurer can't invest that much because for the long term, because they may only have you for a year or two. And the idea is, well, with Medicare for All, if you're always on that, then there can be longer term investments. The reality of the annual budget cycle means that's not automatic.
Well, but I think you're seeing for Medicare and Medicaid, those insurance companies are investing. I mean, they're investing in new models like CareCentrix with care to the home, and you're seeing more and more of that. I actually think that insurers get a bad rap there. There is a fair amount of turnover with private insurance, but for most of the cohorts of people who are covered on private insurance, they aren't chronics. Where there's a need to take care of chronically ill people, I think insurers are increasingly being more innovative and investing in more models to address it.
Fine, John. Well, the drone is gone, but the storm clouds are gathering, and it looks like thunder and
lightning. David, you still taking your sleeping pills either by day or at night?
So, John, there's a new black box warning on these sleeping pills for things like driving while taking a sleeping pill, actually wandering around, cooking and eating.
How about podcasts?
Well, John, what I was thinking was actually I'm going to go, take my Parkinson's pills that cause compulsive gambling with the ones that cause me to go and drive while I'm sleeping. I'll go to the casino, sleeping, put it all on red, and win big.
You shouldn't make fun of these. These are real risks. People use these pills every day. The black box warning is a really good thing. I'm glad it's out there. Don't necessarily stop taking your pills, but you should be paying attention to these warnings. It's a big change and it matters.
John, is weed killer causing cancer?
Weed? Oh, killer. I think that there's a lot of noise right now, and it's quite serious about the fact that this glycophosphate is in almost everybody's bloodstream. I think we've been a little too loosey-goosey about all of the chemicals that could hurt you. The statistic that worries me is that your cancer incidence rates for kids have gone pretty dramatically up from 12.5 per 100,000 to 18.5 per 100,000 the last time I checked over a 10-year period. And that's an indicator, I think, that we may be poisoning our society. So I don't think we really know. It's a complicated thing, but I think we ought to be paying attention.
I saw an FAQ from an expert and it said, how much is too much? And they said, it's not known.
Well,
John, you're pretty arbitrary. Do you believe in arbitration for drug pricing?
I think anything that makes the conversation with drug companies more transparent about how much we're overcharging is a good thing. I'd be willing to try it to force the drug companies to come to the table with fairer prices. What about you?
No, I think when President Trump retires, he may become the drug czar and he can set all the prices. I'm for that.
Can technology make healthcare more human?
I think it could, but I think what's more likely is you're going to go from a doc in a box to a doc in a bot. And I worry what's going to happen is you're going to actually have artificial technology, artificial intelligence instead of people. So
you have artificial fears to match your artificial intelligence. I think that technology is our friend, and it won't make us. Technology doesn't make anything more human, but it could create more room for more clinicians and, frankly, patients and families to inject more humanity in healthcare.
Paging Dr. Aspartame. Well, we've reached the bitter end of another edition of CareTalk. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for watching.
Take me to your leader.
Hey there, listeners. Want more CareTalk? There's more to be had in our other episodes, so be sure to look for those and subscribe to CareTalk on your favorite service.